Good morning, thank you. So we've actually had our colleagues set this up very nicely because we've talked about marijuana, we've talked about probiotics, and we're going to touch on that in the context of pregnancy. So prevention first, and then management after that. So in the preconception time frame, an ounce of prevention is worth a pound of cure. We've seen this, and here are the data. This is out of the Rotterdam group, that they have a specific preconception counseling clinic in as little as 30 minutes. While they say little is 30 minutes, obviously to us it would hopefully be toned down to about 10 minutes, but that counseling can lead to less disease relapse during pregnancy. So the rubber hits the road here. So this is a very nice prospective study done over 5 years of women of childbearing age attending IBD pregnancy outpatient clinic. They had a study group and then a control group, and were able to show, compared to the controls, the increased intake of folic acid, smoking cessation, which is important for all of our Crohn's patients, not just the ones who want to get pregnant, the discontinuation of IBD meds due to concerns of side effects. They were able to counsel that you shouldn't stop them. It was interesting that the periconceptual disease activity wasn't different, but what that meant was that patients were pretty well when they're having this conversation, and that didn't change, which is a good thing. And again, very important that the disease activity during pregnancy was significantly lower in those who had had some preconception counseling, probably due to the smoking cessation and the lack of discontinuation of their meds. So an ounce of prevention, pound of cure. All right, so let's move on to some pregnancy issues here. So we're going to talk about some non-IBD meds first, but are used very commonly by our IBD patients to control symptoms. So loperamide, our pouch patients are ileostomates who are taking loperamide to prevent dehydration and volume depletion when they get pregnant. What are the data? Well, it turns out, so if there are fellows in the room, this is really low-hanging fruit to look at this. Here is the literature, is the Swedish birth register. 43 cases are reported, and a quote, few of them from this population actually had IBD. So the data are very scarce, and there was a signal for congenital anomalies. So that sounds kind of scary. If you go to Dr. Google, it says that there are data that are associated with an increased risk for congenital anomalies. Suddenly your pregnant patient isn't taking her loperamide, and she gets hospitalized for her dehydration. So take-home point here is that the data are so scarce, and it's much worse for my patient to become volume depleted, that if she is using loperamide to control her diarrhea for her pouch or her stoma, that I continue it. A patient who has not been on loperamide is pregnant and develops diarrhea. I'm doing a workup. Why is she now having diarrhea? And I'm not just going to say start loperamide. If it turns out to be functional diarrhea, I'm going to push that fiber. We heard about probiotics, and women, again, who are taking probiotics before they get pregnant, can they continue them, or should they start them during pregnancy? And it's interesting that there have been data to look at pregnant women starting probiotics for different non-IBD indications. This was a paper for bacterial vaginosis to prevent it, because the presence of that can lead to chorioamnitis, which leads to preterm delivery, which is already something we're worried about in our IBD patients. That probiotics are effective in the non-pregnant to treat bacterial vaginosis, and that there was a randomized controlled trial looking at using lactobacillus species for 8 weeks before 12 weeks of gestation, and there was no difference in the vaginal flora. So it was well tolerated and safe, but it didn't seem to have any effect for this indication. But for my patients who are on probiotics where it's helping whatever symptoms they have, I don't have them stop their probiotics. If they want to start because they've heard that it may be healthy, that there aren't a lot of data to suggest that. All right, we heard about medical marijuana. So in the pregnancy state, what about medical marijuana? This is data out of Texas, and this was a retrospective cohort study of just women in the pregnancy state, not specific to IBD. There were 106 women who admitted to THC use during their pregnancy, and of those 106, half of them were also still smoking. If you look statistically at just marijuana use alone, it was not associated with an increased serious adverse event rate for mother or in the neonatal time frame, but in combination with tobacco, it was associated with an over twofold increased risk for maternal asthma, preterm birth, low birth weight, decreased head circumference, and preeclampsia. And there's actually newer data that I showed at the ACG meeting looking at THC use in pregnancy, again, not in the IBD population, but specifically that it doesn't seem to affect maternal health and outcomes, but long-term, actually neurologic development of the child, which makes sense. So we try to use alternative therapies for those patients who are using medical marijuana, particularly when they're pregnant. What about endoscopy during pregnancy? This is very nice data, again, out of the Rotterdam group. This was a case control of specifically IBD patients who were pregnant, who were matched on age, medication use, and disease activity to non-pregnant women. 42 underwent 47 lower GI procedures over a 6-year time frame, and they were able to show very, very confidently that the median birth weight was lower in the cases, but there was no difference in spontaneous abortion rates, gestational age, birth defects, or APGAR scores. So probably the median birth weight lower in the cases had to do with the fact that they likely had disease activity, which is why they were having an endoscopy. But certainly you are not going to induce a spontaneous abortion or have a child that is born earlier, and certainly it's not, your endoscopy is not going to affect their congenital abnormality rate. And again, out of Sweden, the Swedish Birth Registry, and this is Jonas's work, looking at all of the population of Sweden, and just looking at the general population, not specific to IBD. 2,000 EGDs were performed, 1,100 colonoscopies, and 58 ERCPs in pregnant women, compared to 1.5 million unexposed pregnancies as the controls. That exposure to any endoscopy, whether that was upper, lower, or ERCP, was associated with preterm birth and small for gestational age. But again, no effect on stillbirth rates or congenital anomalies. So of course, we're always worried about what is that manipulation doing of that scope. And interestingly, that if the patient was having the endoscopy for a non-IBD, non-celiac or liver disease indication, the preterm birth risk went away. All right, so now we're going to talk about IBD meds, and I'm going to set the stage for Mina, and again, remind everybody that we have this very robust database called Piano. And just to remind everybody that the PI is Uma Mahadevan, who deserves the lion's share of the credit here for putting this together. 30 IBD centers, but also community practices contribute to this. We now have over 1,500 IBD women classified based on drug exposure between conception and delivery. So the unexposed group are those who are on steroids, 5-ASAs or antibiotics. Group A was the azathioprine or 6-MP. Group B are biologics, and Group AB are the combination of thiopurines and biologics. And so exposure was defined as any use of a biologic or a thiopurine at any time from 3 months before the last menstrual period to the end of the pregnancy. Pregnancy outcomes were between different exposure groups, and that the offspring of exposed women compared to offspring of non-exposed women during the same time period, and now we have funding up to 4 years. So what do we know from Piano about corticosteroids? So we have 958 women followed 1 year post-delivery in the Piano study that's ready to share. This is the corticosteroid exposed patients, 232, versus the non-exposed. And again, this is prospective data and it's national. So we have about equal numbers exposed in each trimester. And what did we find? So the outcomes are significantly associated with steroid exposure during pregnancy, that there is an increased risk for preterm birth, low birth weight, and no surprise gestational diabetes. Not for spontaneous abortion, not for congenital anomalies, which is what Patients are worried about, is my baby going to have a birth defect if I go on these steroids? Clearly, these outcomes are linked to the fact that there is disease activity that we are needing to control with these steroids because, again, adjusted analysis found no difference in spontaneous abortions, intrauterine growth reduction, C-section rates, congenital malformations, NICU stays, or infections. So the steroids are used to control the disease, and the baby does not have any deleterious early outcomes from that. So thiopurines, am I doing? Oh, okay. All right, I'm going to switch over and let Mina do the rest of the piano and biologics.
All right, so thank you so much. So we're going to move on to the thiopurines, specifically azathioprine and 6-MP. And a prior meta-analysis from 2013 found no association with either maternal or paternal thiopurine exposure and congenital malformations. In the piano study, they looked specifically at thiopurines, biologics, and combinations, and focusing just on the thiopurines compared to non-exposed. Those who had exposure had no increased risk of complications, inclusive of spontaneous abortions, preterm births, low birth weights, or congenital abnormalities. And in a technical review from the AGA, they concluded that thiopurines are safe during pregnancy. And I think this is really important to drive home because of the unfortunate pregnancy class D labeling that thiopurines received based purely on animal models where they were given intravenous thiopurines at much higher doses. And I have personally had a number of patients who've gone to fill their thiopurine prescription and been told by a pharmacist, well, you're poisoning your baby. And the patient calls me up crying. So it is important, again, to discuss this with patients before they get pregnant so that they are aware that this is safe. Now, due to the risks of leukopenia and pancreatitis, it is not advised that we start this therapy during pregnancy, and especially as pancreatitis has been associated with significantly increased risks of adverse outcomes, including preeclampsia, preterm birth, small for gestational age, and intrauterine fetal demise. Now, before we move on to the safety of biologics in pregnancy, it is helpful to understand that infliximab and adalimumab both have an IgG-Fc region in the tail of the antibody that is not present on certolizumab. And in pregnancy, there's active transport of IgG across the placenta. So this means there is transport of the infliximab and the adalimumab. The majority of this transfer occurs in the third trimester, as illustrated on the figure on your right, showing the concentration of IgG in the umbilical vein by gestational week, but you can see that transfer occurs as early as week 18. Furthermore, IgG that's transferred via the placenta lasts longer in newborns than in mothers. So the question is, what are the risks from this? Specifically, what are the risks to the newborn, and what are the risks to the woman and her disease during the pregnancy if we choose to stop these medications? Well, in a prospective study of 100 women who stopped their anti-TNFs at week 22, only if they were in a sustained clinical remission, there was no difference in outcomes compared to those who continued their medications. However, in a much smaller prospective study from Europe of women who stopped their anti-TNF therapy, about 20% of those who stopped either had a flare of their disease or needed to change their therapy due to a loss of response or an allergic reaction when resuming it post-pregnancy. So these risks do happen, and it is important, therefore, to think about the entirety of the pregnancy, including the woman herself and her disease activity. Now, despite measurable transfer of drugs, several cohort studies have found no adverse outcomes associated with exposure to biologics during pregnancy. The TREAT registry, which is this prospective registry of Crohn's patients on infliximab in North America, found no difference in miscarriage rates, neonatal complications, or fetal malformations. The infliximab safety database, which includes all women, including non-IBD women exposed to infliximab, noted no difference in pregnancy outcomes. And a single-center study of over 200 IBD women exposed to both infliximab or adalimumab found no difference in outcomes either with exposure. In the piano registry at last count, there were nearly 400 women who had been exposed to biologic monotherapy and another 100 who were exposed to combination immunosuppressant therapy. And as shown in the lower table of medication safety adjusted for disease activity, those exposed to biologics had no increased risk of adverse events, including congenital abnormalities, preterm births, or ICU stays. Now, there was an increased risk of C-sections. That's likely because you had these Crohn's patients who had perianal disease and therefore needed to have a C-section, as discussed yesterday. The piano registry also looked at women who were exposed to combination immunosuppression therapy, found no differences in spontaneous abortions, intrauterine growth retardation, C-sections, or congenital abnormalities. But they did find an increased risk of preterm birth, low birth weight, and NICU stays for ulcerative colitis patients who were on combination immunosuppression. A sensitivity analysis showed that these UC patients were more likely to be on corticosteroids, and when analyzed separately, it was this steroid exposure that was driving these adverse outcomes. Now, as shown or discussed previously, anti-TNF levels do increase throughout pregnancy, especially it seems with the infliximab as shown in this study. Despite this, when specifically looking at women who had exposure to the biologics during the third trimester, the PIANO study found no increased risk of preterm birth, disease activity, or infections in the newborns. And the PIANO study also looked at infant, maternal, and drug cord levels and infection risks in the newborns at weeks 4, 9, and 12, months 4, 9, and 12, and found no association between risks of infection in the newborns and drug levels present at birth. And this finding persisted even if they included or excluded otitis media, the most common childhood infection, or if they looked at drug level as a continuous or categorical variable. Now, unfortunately, there was a case report from the UK of fatal disseminated infection in a newborn, and this was a baby that was born to a Crohn's mother who had been on infliximab monotherapy at 10 mg per kg every 8 weeks. The baby was healthy, delivered on term. The mother did not breastfeed, and at 3 months, the child received the BCG vaccine and unfortunately passed away at 4.5 months of disseminated BCG. Now, notably, subsequently, there's been a case series of 15 children who were exposed in utero to biologics, anti-TNFs, who also received the BCG vaccine and had no adverse outcomes. But current recommendations are to avoid these live vaccines, such as the BCG and rotavirus, in infants who are exposed in utero to biologics. Now, the PIANO registry also looked at responses to other vaccine titers, specifically H-flu and the tetanus vaccine in unexposed and exposed children. And protective titers were similar across exposure status, ranging from 50 to 78% for H-flu and 50 to 85% for the tetanus. Notably, however, these rates are substantially lower than what you would expect based on historical vaccine rates, which are 90 to 100%. But again, no difference between exposure groups. Now, moving on to the alpha-4 integrants, we do have some data for vedolizumab, but it is quite limited. The vedolizumab clinical development program reviewed their data through June of 2013. This was published this year. In this program, female participants who became pregnant were asked to discontinue the program, but they summarized their data descriptively. So there were 27 total pregnancies in females, including 24 vedolizumab-treated women, resulting in 12 live births. 2 were preterm. 1 had a congenital abnormality. This was an agenesis of the corpus callosum. It occurred in a healthy volunteer who conceived 79 days after receiving a single dose of vedolizumab. There were more elective terminations in the vedolizumab-treated women. There were also 20 pregnancies in partners of male patients, including 16 vedolizumab-exposed partner pregnancies, resulting in 9 live births, 2 spontaneous abortions, 2 elective abortions, and 3 undocumented outcomes. We do have mostly again, descriptive data on ustekinumab. There's 1 registry and 4 case reports, case series of the medication. In some, this is about 108 pregnancies. There was about a 14% miscarriage and elective termination rate and a 1.7% rate of fetal malformations. This does not represent an increased risk of malformations, but due to the very limited data, again, it's not recommended that it be used throughout the pregnancy. Small molecule agents are up and coming, including the oral JAK inhibitors, very new, not a lot of great data. Most of it is animal-based, where there has been shown to be adverse outcomes. Not surprising, as JAK inhibitors, or JAK is involved in placental growth factors, vascular smooth muscle, and placental trophoblasts. UMA did present data a week ago at ACG on a handful of case reports of women who were on JAK inhibitors and became pregnant. No adverse outcomes, but really no good quality data to date to support any findings. Now, another source of concern for our women is the safety of breastfeeding, and we do have rigorous studies looking at this. So with regards to the thiopurines, a study measured milk and plasma levels of thiopurines at regular intervals in 8 breastfeeding women. They found the majority of excretion occurs in the first 4 hours after ingestion, which is useful if you need to counsel a particularly worried woman. But honestly, you do not have to have the poor, tired, new mom trying to time her medications and her breastfeeding or her pumping, because even in the worst case scenario, the amount in the breast milk was negligible at best. With regards to the amounts of the anti-TNFs, a rigorous study also looked at women and their mothers and their infant levels. Infliximab and adalimumab had extremely small amounts in the breast milk, about 1/200th of the level of the woman. No adalimumab was detected in infants, and even in a woman who went through induction while breastfeeding, there was a negligible amount. And none was noted in the milk of a certolizumab-treated woman. So to date, the piano study has about 800 women followed 1 year postpartum to look at breastfeeding and outcomes. 75% reported breastfeeding. Interestingly, significantly more unexposed women breastfed than exposed women. Hopefully that is not because women were too scared to breastfeed while they were on their medications, but again, if that is true, another place where we can intervene and really educate our patients. There was, among the breast milk in which they were able to measure levels, you can see there were detectable levels of infliximab, adalimumab, certolizumab, and ustekinumab in varying proportions, but all very small. Most importantly, controlling for drug exposure, the piano study has found no increased risks of infections, deviations in height or weight, or lack of achievement of developmental milestones in children of women who breastfed with exposure to these medications. And again, the piano registry follows these children out for 4 years and measures their developmental milestones. No deviations have been found in any of the children who were exposed in utero to these medications or who were breastfed while the mother was on these medications. And as was alluded to yesterday, interestingly, the children who were exposed in utero to anti-TNFs achieved their developmental milestones at a greater rate or a faster rate than the controls population. So in summary, the prenatal period is absolutely critical in ensuring a safe pregnancy for our IBD patients. Address medication safety before your patients become pregnant. Just mention it. I'll tell my patients, listen, just as a reminder, your meds are safe if you become pregnant, and if you become pregnant, call me first. Avoid, whenever possible, loperamide, steroids, or starting thiopurines during pregnancy. We didn't discuss this, it's a different talk, but consider therapeutic drug monitoring with the consideration of holding biologics if the therapeutic levels or there's a stable deep remission. That was discussed yesterday. But remember, the pregnant woman's health is absolutely paramount, and we don't have any evidence that it's going to hurt them to continue these medications, but we do know that active disease leads to bad outcomes. In newborns exposed to biologics, avoid live vaccines during the first 6 months, and once again, maternal disease control is absolutely key. And with that, I think we are done.